game-changing discussions on the big ideas that shape our thinking. This is One-to-One. Previously on One-to-One.
And then you can't fight the system. There's a whole system that exists, and no matter how much you try, and don't forget that this position is an unconstitutional one.
Yes.
You wield some power, but it's soft power.
Yes.
And there's really nothing much you can do. And a very clear pointer towards that statement is the fact that the minute we left Kebbi, a lot of our programs started being dismantled.
And it's a good time to talk about Nigeria and politically. I mean, your experience, your successes as First Lady, if nothing at all, validates the importance of political will. So I'm going to ask you, if our country, if Nigeria were to prioritize just one structural reform to accelerate early detection, and says, what should that reform be?
We have already, and it's the primary healthcare system. The reform has to happen at that level. And we have a primary healthcare system strengthening program, as well as the provision of funding for that level of care. What we're not doing is educating the people that occupy that space. The funds go directly to the local governments, but they just split it. Everybody has his own cuts, and that's the end of it. Some of it goes into the work that they're supposed to be doing, but that monitoring, Professor Patti released a letter a few weeks ago. He called it the Red Letter. This was after the local governments had received the funds, and it was basically to hold them accountable, asking them to be accountable for the funding that they're receiving. We can be better. So if we can strengthen that level and provide screening, low end, not high level, complicated, sophisticated machinery screening. There's a lot of screening that we can do at that level. It will be much better. Then we also need to understand that we don't have to have everything in every local government area. We can centralize some level of care. It's all in our plan, but we don't have to have a mammogram in every little village. It can be in some villages if we map it out properly, and then we do the lower ends like the handheld ultrasounds and things like that. But everybody wants to procure and has this fantastic hospital in their village, but it doesn't work. Who's going to man those hospitals?
Correct.
The health care workers, the workforce is just not there.
Yes, absolutely. And Dr. Zainab, I trained as a primary care physician, and primary care, of course, can become this catch-all for all sorts of many things that legitimately fit under that umbrella. But I'd like to delve a bit deeper and talk to me, since we're talking about community health, about the National Cancer Screening Program, or to whatever extent that exists in our country today.
So a national screening program is supposed to be in existence and implemented at the relevant, so that the relevant cancers are picked up early. Men of whatever age, based on the research and demographics of the area, a Black man should present himself for prostate cancer screening at an earlier age than his Caucasian counterpart. So we say 40 or 45. Abroad, you'll find some countries go as high as 60. But from 40, because if you look at even just the average life expectancy in Black, particularly low middle income country men in Africa, it's much lower.
Yes, of course.
We don't live to that high age. So the screening has to come earlier. So basically, there should be a system in place for the common cancers that we can detect, of which there are quite a few. And the system, the plan is there,
Yes.
but there is no system that is implementing it. And that's where the primary health care is important. And strengthening that level of care, providing the human resources that we need to be able to detect it, to carry out that plan. And then the use of technology. We have digital technology now that is really, really racing. AI is just racing through the roof in so many aspects of healthcare. But again, we're being left behind.
Yes.
The artificial intelligence models that will be presented to you today for breast cancer detection has just about 1% of African models in it.
Of course. And that's the thing, of course, about technology. It's you don't use it, it leaves you behind.
Absolutely.
Doesn't it?
We're already behind.
But I'm going to stay on this, and the plan is there, the system is there. But talk to me about the nuts and bolts of this. How do we get this screening program properly off the ground?
Well, starting by making health and the whole system an area where is sexy to our children. Let them be able to want to be a nurse.
Yes.
Not see nursing as a dead-end career where you just go on night calls, or to be a technologist in the lab or medical physicist. These are all, not everybody, sounds cliche, you don't all have to be doctors and lawyers, but everyone comes out of their homes thinking, oh, I'm an art student, I'm going to be a lawyer. I'm a science, I'm going to be a doctor. That kind of thought process has to change, and we need to educate our children on the plethora and wide variety of careers that are available. I mean, we're all guilty. My daughter told me she wants to do chemistry because she likes makeup and she's going to do makeup. And I said, yeah, chemistry.
So guilty as charged,
Well, she had her way in the end. Guilty, yes, to an extent. And she's of a different generation, and they know how to get what they want, So she, in the end, she got what she wanted.
Yes.
But we need to all be more open in our thoughts and how we think about it, and of course, funding it. How do we fund those screenings? And effectively, let us get the resources to that level of care, and then we can start to get low-end technology that we can use that will be deployed widely and is easily accessible. Our nursing colleges are not enough. We have to increase the capacity of our medical laboratory colleges, nursing college, and the capacity or the numbers that they can take and how much we train. We have only 2 colleges in Nigeria that are training oncology nurses. The rest of them are just ad hoc hands-on treatment. So there's a lot of things we take for granted. We had no radiologist in Kebbi. We finally got one, and I think the FMC got 2 as well. But it took a lot to get people. So why do I have to go to Enugu to start begging somebody to come to Kebbi? Where are the Kebbi people? Why aren't they going into that specialty? So it's all about, training them and reorientation, getting them to be aware that we need these specialties, we need these, more resources to be deployed towards them, and making it conducive. We had to offer that bit extra to get them to come, but it wasn't a problem. The government was very, very happy to do that as long as we were able to provide the people with that care that they need.
Sure. Of course, for further compounding that as a problem is the fact that we are hemorrhaging talent. Jackpot.
Yes.
Of course, that's not helping, is it? Okay, so I'd like to move on now to talk about you and the wonderful things that you are doing globally. Okay, you are. As of now, President-elect of the Union for International Cancer Control. And that's one of the most influential cancer prevention bodies worldwide. You are, in fact, the first African to hold that position. You previously served as a board member from, I believe, 2020 to 2024. So you've done the night shift, haven't you? So what does this moment represent, in your view, for Africa and for low and middle income countries in general, in terms of global health governance?
Okay, so I think that my experience in different ways for the past 20 years contributed to that position. And though I was a board member for, I think, 3 terms before being elected, it was the work that I'd been doing prior to that global position in our communities that really spoke. And one of the first things they tell you when you come on the board of the UICC is you're representing cancer control. You're not representing your countries. However, 2 days later, you will get an email asking you to speak about breast cancer in Nigeria. So my colleague from Sweden is not going to get that email. Like I won't get that. So in a way, it works for everybody. I bring my experience to the table,
Sure.
and that is what has helped me to get to where I am. And it's important that for the first time we have a representation clearly from Africa with the ability and the understanding and experience of what it's all about and how we can do it. So it's not textbook. I speak from experience, I act from experience, and I intervene in the organization's plans from experience of a low middle income country. And more, again, very importantly, I try to bridge those two ends. I have worked in a high-end country, high-income country. I have seen the systems there, all this primary health, calling up digital technology. You get a letter, you get a text message, you get an email, everything calling you to come for your breast screening. Once you hit a certain age, the system knows you exist. Are we registering all our people? Do we know that they exist? So that kind of strong system, it comes to play from different aspects. It's not the doctors that are registering. It's another department in government. The doctors give birth, and yes, the hospital registers the birth, but someone else is responsible for the data of the country and planning and getting to where they want to be. So I can see that in my dreams. I've seen it, I've lived it, and I want my country and countries like mine to catch up. So if I see an organization like Gavi wanting to provide extra vaccines or for some other disease, I can cut in and say, no, let's allocate more to rotavirus, which is killing children, diarrhea all over the place, as opposed to that. And I think it's worked well and it's working.
So it's no secret, of course, that diagnostic access remains one of Africa's greatest weaknesses. Precisely what needs to change in order to make diagnostics truly accessible and of course, that word, affordable to communities?
Again, it's the system. It's a matter of how do we, when you talk about diagnosis, people think of it as one big machine. I need to buy this machine. Okay, fine. Buy the machine and bring it home. Where is the power? How stable is the power? You've set up your beautiful machine and there's one surge and the motherboard is gone and you have to wait for 6 months before it's replaced. So the system, the power, the backup that we have in place, when we started the diagnostic center, and even till today, we have to have a generator, a backup, a backup generator. Now we have inverters, we have a dedicated transformer, we have solar panels, but it will still blow your machines up and it will still go down. So, and who is going to fix it? How many engineers are we training? And how do they get deployed around the country? So diagnostics involves not just the system from the government side, provision of the right type and amount of electricity, and then numbers. Numbers will help us. One of the Renewed Hope agenda things is to deploy these machines in greater numbers. And we've recently seen a lot of movement in that direction. More cancer centers, more procurement of the equipment, and more training slots in our hospitals. The number of house officers that we're taking, and it's a whole system thing. I'm bringing it up gradually, and of course getting the awareness into those communities so that we can allow our children to go to school and learn, and hopefully they will be able to operate those machines. Media has a huge role to play in how we negate or hail these efforts. A lot of times, efforts by government are not seen as any big deal, and it's difficult. Having sat there, there are so many priorities. You're talking about insecurity in one end, you're talking about increasing salaries in one end, and there's so many things that you have to juggle on the resources. Luckily, after the removal of subsidy, we now have more funding to do maybe capital projects and even ongoing ones to enable some of that flow more. But I'm sure the average Nigerian would think this man is just talking rubbish. But it's the reality. We have to also do a bit more on our side, and education is so important. Once we know the value and we enable our children and allow them to go to school, they will grow up into, and like I said, this generation, they're really something else. They will be able to grow into careers that will help us towards building a better nation.
Sure. And of course, I mean, just going back to talk about screening, very quickly, but part of the point of a screening tool program, I mean, thinking about accessibility and affordability, part of the point of it is that it ought to be cheap, rarely available, reasonably specific, quite sensitive to pick up what it is you want. So I'm going to ask you just very quickly run through two very basic examples of screening programs for conditions that have a huge impact socioeconomically on the country: cervical cancer, for example, and breast cancer screening. Just see the two simple examples of screening programs that can be put in place. If you could talk a little bit about that.
Yeah, with cervical, it's easy. We have a clear map, we have clear tools: vaccinate, screen, treat. That screening, we target women from age of 45 to screen them at least once in their lifetimes with a high performance test. These high performance HPV is the vaccine, is the virus that causes a lot of cervical cancer, and the screening method is available.
What is that screening method?
It's a molecular test that machines, the COVID machines that we procured in every, if you remember when COVID came, there was a huge outcry. This is where press can be of help. And a huge outcry that Nigeria has only one molecular testing center and one ventilator and things like that. And this state, it will be this state they pick on today, another state, no isolation, or they will show the isolation ward looking raggedy, and then we'll all run and, prop up our isolation centers, procure ventilators, procure molecular testing machines. They're there. They're now available. So that map changed gradually from the NCDC. Every state had the molecular testing machines. And what are we using them for? We can use them to screen for HPV virus. The human papilloma virus is, we can screen for it. And any woman that is picked, we know that she has to be screened more regularly, and we have to look for changes in her cervix. And she can also have easy to use treatments which is just something that you do in an outpatient clinic using cryotherapy. That's the use of like cold to freeze the cells before it becomes cancer. But how do you know that it's going to be, she has that lesion? You have to look and see that she has the HPV and the lesion. So if we can, that is easy. That is an easy one. And those are the WHO targets to meet those goals by 2030. We're not going to reach it by 2030. There are countries that will. Even in Africa, we have Rwanda. They have a mission 2027, actually. They hope to meet it. But these are lower populations. And Nigeria just started, like we said, our own vaccination.
But we have machines, as you say, all over the country. So that actually locally would sound as though we're only a few steps away.
Yes, but where they're not being used. There is no national screening program. And even either private, public sector, they're not being used to screen. Some centers use it for tuberculosis and HIV, but the system is not pushing for HPV screening, which is what, as the Cervical Cancer Task Force, we're trying to implement. We have a plan specifically for cervical cancer, but it's not being implemented. We're able to get funding, more and more funding as the days go by, but it's still not enough. The number of women that we need to screen in Nigeria is about 60 million. And with the machines, we need more machines. We need the reagents for those machines. We need the manufacturers of those machines. So if you remember HIV, the price of the antiretrovirals was crashed, and it was, like next to nothing, something like $5. So we need those reagents to be at that level as well. Right now, to do a screening costs us something like $15. In India, they do it for about $1.
Right.
Yeah, so we need to get to that level.
Yeah. Well, thankfully, you'll have the lever to try and force some of those global targets, rather than when you leave in 2026. So thinking about how to move the healthcare sector forward, how do you feel that government, the private sector and civil society ought to work together? What sort of partnership model and framework?
Well, partnerships, multi-sectoral partnerships, we ensure that from the start of a plan and intervention, we include everybody, bring everyone to the table, all the players, those who influence and are able to make a change to cultural beliefs should be a part of designing programs that are going to improve cancer. So that it's very important that government works with. It's there, we play lip service to it, but it needs to be more practical as opposed to just playing, symbolic mention and having representative of civil society on boards and so on.
Absolutely. And of course, the existential problem that confronts healthcare in this country is funding.
Yes.
A huge part of that. You can't have the funding or finance conversation without talking about insurance. So tell me a bit about that and how you feel that plays.
Well, it's a sector of finance, that health financing, that has started to gain more prominence in Nigeria in the last 10 years. We now have states that are providing health insurance, covering the formal sector. That is to say that every state government employee is able to, they put aside a certain amount of his or her salary, and she can access with her family a certain number capitated, and that is working. However, the majority in the informal sector are not being covered adequately yet. So we need to do that more, and it can be done. Universal health insurance coverage is why and how countries are able to progress. People in the UK don't pay for their blood tests or anything. It's catered for by the NHS.
Sure.
And although they don't realize how effective that system is, it's really working well.
Of course.
And that's the model that we need, those kind of models. What works for us? They will tell you the funds are not there, but we can find the funding to put aside every month, even as a saver, just on your own personal numbers. You save every month.
Absolutely. And finally, Dr. Zainab, we've been talking here about cancer. It's a very important, hugely important subject that affects the lives of real people and communities, not just now, also for generations, with huge resource and socioeconomic implications. So I'd like to ask you, who've been so deeply involved in the space for so long, what does dignity in cancer care mean to you as an individual and as a professional? And how should this sort of approach and thinking shape the future of the society that we're trying to build?
Well, for me, dignity in cancer care means that a woman, if we take the commonest cancer in Nigeria, a woman with breast cancer, for instance, is able to know that she has breast cancer early enough to be treated, early enough, and not just being treated. Let her be able to access that treatment. She might need chemotherapy, drugs, she might need surgery, she might need radiotherapy. Dignity means that she can go to a cancer center and wait under reasonable circumstances, not out in the rain, to get her radiotherapy, and not have to wait longer than necessary until the cancer starts to grow to different parts. So we must also take into account the mental health of cancer patients and treat them with care and compassion. And this is the onus here lies on the workers that are delivering the care to them, right from the gates of the hospital to the bed that she lies on to get the radiotherapy. So we need to understand that they're going through we've spoken about so many complex issues, but cancer in itself is one of the most complex diseases that is an interplay of so many different parts of the human body. You have infection, you have the immune system, you have the just genetics and everything interplaying in the wrong way, and then you have cancer. So we need to appreciate what these people are going through and the burden that it places on them, and how we can help them even at end of life care. If we're talking about end of life, it's not about prolonging it. It's about how do we help them to achieve some dignity as they come to us. The brunt of our patients are at that spectrum, but they lie in their homes, fungating, smelling, ostracized, stigmatized, and unable to even end their lives in dignity. So providing the right morphine, providing the right surgical treatments to reduce that load of, poor hygiene and so on is something that we should consider more.
Dr. Zainab Shinkafi-Bagudu, thank you for joining us.
Thank you for
ONE2ONE.
Thank you for having me. It's a pleasure.
Real pleasure.